Medicare and Medicaid, get the agency number, but I can't just have the CON process go through and let that go for 3 months because DOH wants it to happen within 45 days.
Okay, so you're requesting provisional approval, pending all of the above.
Preventing, yes. Pending ALS status, pending the Muni COL.
And the ambulance, and so the controlled substance will just transfer over. It's a new, is it a new agency that you're creating though?
I am creating a new agency. It'll have a separate agency code, but I just found out that the controlled substance license can live, both agencies can operate under their current controlled substance license.
So ALS FR that's established now is a separate agency from what's being created, is that right?
They'll have separate agency codes, correct? Same agency operating, they have different agency codes as far as the DOH is concerned.
So I guess I'm going to ask the state to weigh in because there's a lot of things on that laundry list. So you need an ambulance, you need to get it inspected, you need to get it stickered, you need controlled substances attached to that ambulance service. You guys have any reservations about a provisional ALS status? Did you hear my question, Mary?
I'm sorry? No, I didn't.
All right, we're calling on the Department of Health to weigh in on.
I thought that's why Joe was moving closer to you. Sorry. He is.
I know, but we're still awaiting the response. So, did you hear that whole conversation?
Yes.
Okay. So, MSIB's requesting provisional ALS, but for an ambulance that doesn't exist yet. I guess it's coming.
Right.
Free shipping. With attached controlled substances.
This is the last
and it's a new agency. It's a new agency, new ambulance, new controlled substance. And what do you think about that?
Yeah, that's not an. I mean, that's not an issue. They have to do the Muni. They could do the Muni declaration. I mean, the other way you can handle this, because of the timing of everything, you can either say, okay, it's provisional now, or give Phil the authority. Then when Tony says, look, we have everything, we're going ahead, we've made a Muni declaration, you can give Phil the authority to do it then. I've seen it done both ways.
Oh, okay, so it comes from the region.
It has to come from the, New York State grants the ambulance BLS certificate. The docs have to go above that.
Okay.
DOCA is technically a new agency under a new agency code, but all the players are the same.
Okay. All right.
I mean, he's been working diligently along with us to be sure that the controlled substances piece goes through and everything else.
Okay. Phil, you okay with working during the summer?
Yeah.
Okay.
Yeah, I go anyway.
All right. So all those in favor of provisional approval of ALS pending all of the above? Any opposed? All right, it's approved. All right. Next, informational. So these guys are coming back online because they just went through that process.
Springs and Sydney, they're back to ALS level of service at this time.
And this was similar. They were suspended because of controlled substances, and they got caught.
That's it, and they got their licenses.
And that's
so they're all set to go.
after daily modification. Okay. All right. So Paseco, that's way up there, right, Phil?
That's right next door to us in Speculator, yes. That's, they are requesting approval of the glucometer program pending receipt of their CLIA waiver. There's a little story about this. They had a CLIA waiver once upon a time there, and they had a change of leadership a couple of times over in the meantime, and all the paperwork is gone. All of it, gone. So they have requested from the Wadsworth Labs a new CLIA waiver. So they're just requesting, all their paperwork is in order minus the CLIA waiver. They're just requesting that they, the REMAC approve them for glucometer once again, pending receipt of the waiver.
Okay, so it's really just a documentation.
That's it.
Yeah. And the second thing relative to Paseco's.
Paseco wants to, again, they were approved for nebulized albuterol once upon a time. All the paperwork got lost, so they just they refiled their paperwork with us, and they just requested formal approval again from the REMAC.
Okay, so let's do these together. Glucometer approval and nebulized albuterol approval for Paseco volunteer fire department ambulance. All those in favor? Any opposed? All right, so that approves. Mr. Farrell, you're up. Update on the status of basic life support first responder agency recertification.
I'm sorry, BLSFR agencies in this region are well up to date, or at least in the process of being done. So everybody gets a gold star.
Okay, how about the recertification and inspection requests? Are they up on that too?
Everybody's up to date.
Up to date. Good.
Okay. Let's hold on the protocol thing first. Sydney EMS, which is, this is, but not MFI. Okay, so that's part of the other discussion. We want to discuss the Fulton County SCT and MFI programs. That's right, we had a large discussion last time about that. So where are we at on the discussion? Is it pretty much the same discussion as Sydney?
No, we've gone through their MFI program. We've contracted Kevin Roberts from Wilton, not from Wilton, I'm sorry, from Clifton Park Half Moon. He's a political coordinator down there. So he went through and reworked our MFI policy. He's also set classes for us. He's a CIC. We've contacted, or we've been working with Dr. Glenn. Currently we have 6 providers that are currently completed with their MFI credentialing. And we have all the documentation along with it.
Okay, that's good. So there's 2 parts of this. One is the SCT linkage to MFI. Is it assumed by this REMAC and council that there's necessarily a linkage to SCT and MFI? In other words, you can't be SCT without MFI. That's one position. There's an alternative position that says they shouldn't be linked, and that you can be specialty care transport without RSI, MFI. So that's, you guys went ahead and did it because the sentiment last time was that you had to have it.
Correct.
Okay. And the program itself, the MFI process, certification process, is that well defined within the region?
Yes, it's we have 8 hours of didactic course material plus lab time as well on top of it. And then at the completion of it, Dr. Glenn gets a list of people who completed, and they make appointments with him to meet with him one-on-one to get signed off.
Okay, so tight medical control for that.
Correct.
Okay. So there's 2 parts to it. So it sounds like we have a regional MFI curriculum, right?
Mm-hmm.
That you can, this is all completed, at least partially completed in the process. Is that right?
There's 6 medics that have completed it.
Okay.
Some others are too new to really complete the requirements, is that you had to be at least a year online within the region.
Okay, so is this informational, Phil? It's down here as informational.
Informational and for discussion, because I have not received any paperwork from Fulton County regarding their MFI program.
Okay. And you received previously the SCT application,
Oh, yes.
right? Okay.
Yep.
So this is like related to and appended to the SCT application, right?
Mm-hmm.
Okay. So how long would it take you to get the MFI materials to Phil? There they are. All right, there it is, Phil.
Oh,
You
okay.
just-
Very good.
We can witness the delivery.
The camera sees all.
We'll give Phil the 30 seconds to make sure it's all in order, and if so, we can then proceed.
I don't think we have a regional
Curriculum.
curriculum, by the way,
Okay.
because that seems a little short, but as long as we're not in director, is okay?
The fact that the region hasn't put pen to
Okay.
paper doesn't-
I have their paperwork.
Okay. All right, good. So there's really nothing further to approve, right? I mean, they're SCT, they have MFI. There is some discussion down in my neck of the woods here that the region does not have a defined MFI curriculum, but that hasn't stopped us before. So we can, in the process, I think, witness what happened in Fulton County, what you guys did for that, what GAVAC has done, past for that, what CMT is preparing to do for that, and maybe, you know, some oversight blending of those three approaches could define what, you know, what it is, what it should be going forward.
I think we kind of set precedents when we accepted GAVAX, and I went and am stepping off from GAVAX plan to develop mine, so.
All right, so is there anything to approve for Fulton County, Phil?
I'm sorry?
Is there anything to be approved with regard to Fulton County?
Yeah, we're just awaiting the REMAC final decision on their SCT/MFI program. Slash is a bad word, but you know what I mean.
Well, it's SET with MFI, right?
Right.
Okay. So, any opposition to Fulton County proceeding with SET and MFI as described? Any opposition? Comments? All those in favor? Aye. Okay, so that's approved.
Okay,
So,
program is approved.
one up above that,
Can I just
Sydney.
ask a procedural question?
Sure.
Along the SET, and just click with what Beth said. So if we're taking it saying that you have to be MFI before you can be SCT,
Well, we haven't, that's a separate discussion. These guys, that was their assumption after the last meeting.
that was pretty much the way the discussion was going the last meeting,
Right.
okay?
Right.
So what, are you putting any time constraint on like CMT to get up to that level? Because technically,
I'll be bringing it to the September REMAC.
because technically they shouldn't be SCT then by that premise.
They're in
right now.
process.
Mhm.
They're
Yeah,
in
I think-
process of
You know,
credentialing.
it's still, you know, that,
And I'm just asking the question here procedurally.
well, we haven't, I don't think we've said, there's been an assumption, right? I mean, Fulton County, in good faith, went forward with MFI training because they thought that the wave of change was going to require it for SCT. There is an opposing opinion, and Dr. Markowitz, for example, thinks they should not be linked. That MFI is not a prerequisite to being SCT. So we can't, I don't think we can shut down CMT.
No, I'm not saying shut down, but I'm just saying,
So-
is there some type of like plan of correction?
Well, it's not a plan of correction, I think we're evolving. Well, the first question is it a prerequisite for SCT? If we say yes, then we're kind of,
The REMAC has not said yes to that, Gus.
Right.
At the March meeting, there was a discussion talking about the advantages of linking MFI on with SCT.
Yeah.
But there was no hard and fast decision made. It was just a
Right.
discussion. There was no vote taken.
right, I think there's at least two opinions about that. Dr. Markowitz isn't here to defend his stance. Is Dr. Markowitz the Sydney EMS medical director?
He's not.
He's not, okay.
He's working closely with us, but he's not our medical director.
And I think, I think what Dr. Markowitz, and I don't want to speak for him, but his opinions around RSI is that it may not be an ideal procedure to put in the hands of low-volume rural squads that don't have perhaps a lot of oversight.
Correct, and I tend to agree with
And a
him.
lot of volume and a lot of experience doing it. So it'd be, a rare event in a low-volume squad, right? So the utilization of RSI in an SET, we can all think of scenarios, and I think Tom, put forward the scenario where, an intubated patient is leaving the hospital and becomes extubated en route, and now what do you do? Is that
Re-intubate
is that
the
sort of-
patient.
Or they're so critical because it's an SCT transport that they actually need to be intubated.
So they weren't intubated, and now they're changed.
I mean, I'm not a fan of MFI. It almost killed my nephew because a paramedic / nurse did the procedure correctly, didn't recognize the need to sedate him on a 40-minute ride to the hospital. So I'm just saying, I'm not a fan of it, but I'm just saying if it's good for the goose, is it good for the gander?
Well, yeah, we haven't,
I think that the biggest question with this is, this is already in curriculum for paramedics.
Mhm.
Well, I think the big issue is the agencies have to have a continuing education policy. They have to have an agency procedure and be able to QA/QI those particular things. The actual procedure is taught every day in paramedic school. So it becomes an agency and medical director responsibility on how that gets policed, how the continuing ed goes, what is, you know, for us, we do it every 6 months. We have to sit through an MFI course every 6 months, and you know, we have to do tubes, and you know, every one of them gets QA/QI, but that's just got to be agency procedure and policy. So once those things are in place, and certainly, I would think that also does involve an educational component, for the simple fact that just because you learned it in paramedic school doesn't mean that you didn't forget it. It's something that most agencies don't do, and it certainly needs to be refreshed in any paramedic's mind. I think that once those agencies' procedures are in place that incorporate all of those things,
Yeah.
then that's where it should come to this REMAC for approval.
Isn't it, I see it, we're kind of in some evolution, right? The skill didn't really used to exist. Right? It wasn't really a part of pre-hospital care. It became part of pre-hospital care. So we have large volume SCT agencies in our region who don't have MFI. So, you know, it'd be interesting to see what that experience is. I think Dr. Markowitz is asking for data from Remo to see what their experience is. You know, so
He sent an email to Remo the day before yesterday. He sent me a copy of it.
You've got Deb Cuffs here. You've got Deb right here.
So I don't. So I think Dr. Markowitz, he wanted to like basically study MFI, particularly in the context of SCT agency, and say how often, how well, and just take a look within Remo because you have the largest volume, and maybe we can learn from an region that has more activity than we do.
That particular email that you're referring to actually came to me yesterday. I don't work on Wednesdays. I'm, you know, that semi-retired person. But we were able to pull some data together, not exactly what Dr. Markowitz is looking for, but at least some data for this group to begin looking at. And that is, we first looked at the number of paramedic level agencies in Remo. There are 42, one of which does not share data directly with Remo, leaving us 41 that we could look at. Of those 41, I discarded 4 because 2 of them are the helicopter services, the state police, and air methods, which I presume is going to have an extremely high number of MFI type intubations. The other 2 are the Times Union Center and Ski Wyndham, which are very part-time sort of agencies dependent upon either the weather or the type of venue that's coming to the Times Union Center. That leaves us 37. Of those 37, 17 did at least one MFI intubation between May 1st of 16 and May 1st of 17. The range for each agency, the range for those agencies was between 1 and 73. The mean was 10 and the mode was 2, meaning that most agencies did very few MFIs, even though they were permitted to do that. Taking a look at the agencies that were higher than the mean, one agency has a vast amount of area. It's also culturally probably somewhat similar to areas here in AAREMS in that many folks don't call their responders until they're in extremis. Howard, you could probably speak to that. Until they're in extremis. Several of them are large agencies, large volume agencies, and 2 of them can be thought of as having providers that are probably on the more medically aggressive side due to the agency culture and provider, and I don't mean that in a bad way. I just mean that, you know, known to those of us in Remo, they tend to be a little bit more aggressive. I know that's not exactly the information that you were all looking for. I'll have that for you in the fall, but it's what I could put together last night. So I hope that's something for you to begin looking at.
Yeah, well, that's very
And
helpful.
I will get that to you electronically.
Yeah, good. I was just gonna ask you if you'd CC me that, and I'll spread that around to everyone.
So the 37 number, they're ALS agencies, right?
They are paramedic agencies.
Okay. And are they also MFI credentialed within Remo?
I was not able to discern that from the data I could pick up
Oh,
last
okay.
night.
All right. Because the 17 out of 37 did MFI at least once.
At least once, that's 46%.
Right. So less than half of the ALS agencies do any MFI.
Even the ones that could, the interesting thing is the mean is 10, but the mode is 2. So
Well, the interesting thing is you have one squad that did
can,
73, that's how
do.
you get an average of 10. You have one agency doing 73. So the mean is pulled by that extreme outlier.
Right, that's why I looked at the mode. They're
Right.
doing very few.
Right. So it's a small percentage, well, not small, it's less than half of ALS, right, 46%. And then within that, the mode is 2. And do you have broken down by SCT agencies? They're
I do not.
certified like that?
Again, I was looking from access from home, and I don't have permissions to do everything from my home computer, so I apologize for that, but I at least wanted to start you with the data I could pull.
Well, the folks who also sit on REMO, does REMO have any policy statement with regard to SCT and MFI?
So, I think, respectfully, I think the region, now that we're starting to actually address this, needs to take a look at some definitions and some process first. Because we're using the term SCT, but we're not really clarifying what it is. You know, any medical director can turn around and say, hey, you can transport a patient who's on pressors from hospital A to hospital B, provide in-house training outside of Article 30A, and that's not SCT. So any medical director can turn around and go, look, my staff is competent under my license to do this transport. I think when you're looking at SCT, I think, and I'm just going to throw it out as a suggestion, we need to look at definitions of SCT as things that would meet a national curriculum. So last meeting we talked ad nauseum almost about the Baltimore curriculum. It's commonly known as one of the best two, if not the best. It's a popular one. It's one that I think GAVAC modeled theirs after, and I guess now CMT is looking to model theirs after. I think we need to define SCT, because if a medical director is simply saying, hey, look, we have hospital A that sends to hospital B, and they send on the following medications often, and they're awake, alert patients that just need a ride, that's different. But if we're talking about truly credentialing somebody, allowing somebody, permitting whatever, to do as an agency SCT, you know, the other regions that I'm involved in looks at it and goes, is there a need? Can they prove a need for SCT? Where's the volume? Then they ask for a training package to be delivered to in Remo it's the academic committee, but here it will be the training and ed committee, that then comes with a recommendation to the MAC, and then the MAC either approves or denies based on materials submitted.
All right, well, back up. At the national level, or even
Yep.
Baltimore,
Yep.
is SCT well defined?
Yes.
SCT is defined by CMS
Okay.
very clearly.
So it's a
Right.
billing category?
So there's interfacility and there's SCT.
All right.
Interfacility and this is how CMT looks at it. There is a skills set forth by the state, and there is a formulary set forth by the state. That is the training for every, I'm just going to say paramedic at this point. If the interfacility transport falls within those procedures and medications, then it's an interfacility transport. If it is above those procedures or medications and we have done extra training, then it is an SCT. And that falls in line with the CMS definition as well.
All right, but CMS then leaves the discussion and says, you all figure it out what an SCT is? You don't do burr holes in a root, just as long as your medical director signs off, you're good for it?
The problem is that the national curriculum, the education standards, don't necessarily pair up with CMS. So CMS says whatever you normally do in your scope of care as a paramedic, anything above that is something special, and therefore they term it specialty care transport.
Okay.
But
that's just saying that interfacility is its own category as well.
right,
Right,
but
because-
she's talking about billing purposes.
No, but it's.
But no, I'm
CMS
talking
defines it.
about how do I staff
Right. but-
ambulances?
but
If
you're
it's,
talking-
if it's
What
something
drugs
that's.
can you do and et cetera.
Right, if it's something that is either
Correct.
in that checklist that the state puts out, the comparison chart that says the
Right.
skills,
Right.
or it's in the state formulary,
Correct.
that is what the state minimum should be.
And we were talking about blood. Does that fall to interfacility?
There's a state blood protocol
There's
for
a
that.
specific protocol.
And
on
only
it.
it's an above and beyond
Correct.
Right.
approval.
So it's an SCT level.
No, it's above and beyond.
But,
It's
but
a-
you're kind
it'll
of
be a
playing
state.
apples and oranges here.
Right.
Yeah.
And I know the new collaborative protocols have brought forth even more questions. So I think regionally, the REMAC needs to sit down and decide what they want, how they
What
want
this
to
animal
define
is,
each
yeah.
and understand what the definitions are.
Because you could have like 20 different varieties of SCT.
And, you know, personally,
There's no
I
clear
feel bad for
definition.
ambulances in Fulton County because they've been through this for 6 months and we really don't have a defined process here. So I think good faith effort's been made. It's just a matter of, you know, if somebody comes to this table and wants to do this,
What is the procedure?
what's the procedure?
I mean, I
Exactly.
hate to say it, GAVAC went through the same process.
Right.
They, for like a 6-month period too.
Absolutely. Yep.
So I agree with Howard. We need a small work group to carry this to its conclusion, I think. Beth just volunteered. Howard, are you going to be?
I think I'd like to push Joyce under the bus, seeing that she's not here. But this.
The Education Committee.
There you
right?
go.
Education Committee, we're going to task them with.
The other piece to consider in this whole deal, and it's gonna, and it'll come up in Beth's, or whoever, or Tom's report later, you know, with this, the number of CCs that'll be changing in the region, comparing this region to Remo,
It's not a great comparison.
No.
because they use primarily paramedics.
Right.
Right.
So the skill level and the training
It's another.
is, what is there, a 500, 600 hour difference in courses?
1,000.
1,000?
Yeah,
I was trying to be
so it's
nice
another
about it.
asterisk that makes us different.
That raises a question, should level threes be even doing
And-
SCT?
And that's
Well-
something that the Training and Ed Committee can take a look at.
Well,
Right,
the
so
thing-
what other questions we want the Training and Ed Committee to address?
Hold on one second, Tony.
They don't have to make, I think it'd be good if they came back with recommendations.
Recommendations to the REMAC.
Yeah, so what are the questions we want to put to the Education Committee about all the things we've just been discussing?
Regionally define RSI and SCT.
Oh, our RSI curriculum?
Right.
And SCT definitions?
Minimal definitions for both, but then I would suggest minimal training standards
Minimum skills, training, knowledge, attitude, behaviors
and a suggested procedural process.
for the council. Okay.
Dr. Leinhardt, I'd also like to add in there whether level threes can do SCT transports.
Yeah,
That'll all
that'll
fall
come in-
out.
falls under the
That'll all
come under
fall out.
minimum
Now,
requirements.
what did we have Maggie working on with relation to this,
The MFI,
the MFI stuff?
yeah.
So some of it's already
That should be
started.
pretty easy
Oh,
to
yeah.
put together. I think, one of the discrepancies may be like how many hours of, simulation or whatever needs to be part of it.
We need to take that, the billing aspect out of it and define SCT.
Right.
I mean, they live in, I mean, whether or not the region says, okay, well, the minimum standard is gonna be the CMS standard is one thing, but I think that SCT is far above and beyond the CMS standard.
And we don't even know what it is, because it could be 20 different things.
Well,
SCT without MFI, SCT with pressures only,
You
SCT.
know, heparin on a drip, interfacility heparin on a drip. on a pump is billable SCT, because it's out of the scope of a paramedic.
But is that truly SCT?
But
That's the
it
question.
truly isn't an SCT. You have pressers running, probe,
But so it's
patients on a
interfacility.
vase.
It's interfacility.
It's interfacility.
And it is, I
That's a-
believe, it is a medication covered in the
In a
state
facility.
formulary. So if, you
Right.
know, then it's state training.
No, it's not.
It's not in the state
There's no
formulary.
formula anymore, it's all
There
based
is,
it's all based off the region, what the region says we
Correct.
can have, that's what. they're
right,
doing.
but there is a list of drugs approved by CMAC for choice of use in regional
Shortage.
protocol.
Isn't it for shortage or?
No,
isn't that
there is a
the-
list of medications that are available for choice in regional protocol. And that's what I was going off of.
This is really interesting, because the more we discuss it, the cloudier it gets. So we're going to stop discussing that, and we're going to move on to the protocol itself. We just passed the education committee, and any interested parties, they'll get a hold of Joyce and say we're interested. Yes, Deb?
I'm sorry, before you move on, I just want to be sure that I'm obtaining the information that this group wants.
Remember, it was Dr. Markowitz who requested it, so it didn't come from me, it didn't come from the REMAC, so it's his own
I know,
personal.
but you're it. So of agencies in Remo doing MFI, how many are SCT?
Yeah, I mean, is that, first of all, is SCT a clear, you know, is it a sticker you put on your ambulance? I mean, is it that clear certification?
Yeah.
It's fuzzy as hell,
There's a
right?
patch, if you really want to be silly.
You have your medical director to say you are, right? So that's how fuzzy it is. So you're gonna have a hard time finding out.
So that's
Okay.
also what,
Of paramedic agencies in Remo, how many are doing
MFI capable, that would be interesting, yeah.
And of those doing MFI, what is each agency's annual volume?
Of
Patients?
runs or MFIs? Runs, perhaps.
Runs was the way I understood it, but how would you like me to obtain that?
I don't know, you know the database. The other thing would be the interfacility agencies, like the SCT seems like it's just gotten really fuzzy to me. But interfacility, you know, the agencies that do interfacility, how many of those have MFI or have done it?
You are really comparing apples to oranges with
Yeah.
this data. If we bring an intubated patient into St. Mary's Hospital with a brain bleed, that's going out. You're not, if you bring that patient to Albany Med or Ellis or, you know, most of the hospitals in the Remo region, they're probably not doing those transports.
right,
So even the likelihood or the number of SCT agencies is probably going to be significantly different between regions. It's.
I'm not comparing the number. I want to know agencies that do interfacility transport, which in some worlds it's also SCT agencies. How many of them have MFI? In Remo,
all of them.
all of them.
No.
Yeah,
Or
if you're
doesn't
doing
have MFI.
SCT, if you're doing SCT.
No,
in Remo-
interfacility,
No, Remo.
interfacility.
Oh.
You're going down the road with a heparin drip, it's SC, well,
No.
skip heparin. But
Yeah, Empire's not, but Albany County is MFI, and they don't do interfacility transports.
Okay, so it's,
There's only like, I believe, one or two agencies, maybe 3 or 4 now, that are doing interfacility transport in the Remo region.
oh, really? So they really
Yeah.
boil it down.
Really not
quite
that
a
many.
bit.
And that's directly from Tom's comment, which is there's more choices for.
Right, we're bringing our patients to that region,
Right.
not taking them out.
I think your numbers are gonna be completely skewed.
All right, so let's cease and desist on SCT, interfacility, and all of that.
Is there nothing in the protocols about it
It
anymore?
says specialty care transport.
It says it's approved by the region. It's
Correct.
regional specific.
You can have
Yeah,
The
it's-
question I have, Dr. Lenhart.
No, we're done. Cutting it off, boom, we're moving on to the protocols themselves. There was about 20 gazillion items on the protocols themselves, so let's get to that. Feel free to join, not being rude, but there's a committee assigned to the education committee to carry that whole
I
discussion.
understand 100%, but you're gray as gray can be. You just sat here and told me that heparin is interfacility. Now, according to our protocols, I have to be SCT to transport heparin from your hospital in Sydney to your hospital at Bassett Hospital.
Yeah, it's confusing, right?
Well, can I do it or can't I do it?
Good-
If my medical director tells me that I do the training and train my providers to do it, Can they do that?
Yeah, I think the answer is medical director is sort of the final common pathway for almost
But-
everything.
Okay, that's what I'm looking for.
So, Dana, let's sit down and go through the lists, because
Yeah.
I have sat down with all the lists, all the drugs, and come up with what's considered state training versus what's has been needed to be trained above.
I have a whole list that I proposed to them already,
So, but let's.
asking for SET.
It is confusing because you guys are getting pushed more and more to do more and more between facilities.
Well, absolutely, because you've got a hospital that can't admit, and they're sitting on patients for hours waiting for transport, or we can just go over and do it,
Right, if your medical director says you can.
if our medical director says we can. Thank
Yeah.
you.
All right, so who's got it's not 9,000 items, but there's quite a few items on this list. So just, Phil, read from the REMAC to-do list. Item number 1, read it.
Can we have a clarification there? I could have sworn, and maybe I'm just not hearing right, but I thought you just approved Sydney to do SCT transports
Without a program
without a
submitted.
program.
By our medical director.
We're not, history is the future right now. Whatever's been going on in New York State continues to go on.
So he has to submit a plan to read.
So we don't, the reason for this education committee is to try to get some clarity so that everybody is like, understanding what we're talking about. All right, Phil, item number 1.
Okay, these are the, if I understand you correctly, Gus, this is what I received from Tony Agresta. Some of
Right,
the items
we're reading
that
Tony's
REMAC
list once again.
I'm sorry?
Go ahead.
A minimum for each of the medications in the formulary.
All right, so recommendation from the REMAC, at least times 2, maybe 3, is 2 doses.
2 doses for each.
Yeah.
Oh,
Okay.
2 doses.
You got long transport time. Oh, minimum, yeah.
It's a minimum, right?
This would be the minimum, right?
Right.
So, for example, if you look at epinephrine, 1 to 1,000, you've got, right now, or in the previous protocols, you had 2. In our protocols now, it says epinephrine, 1 to 1,000, 1 milligram per milliliter, under medical control option, 3 milligrams via nebulizer. So we're now going to say 6 vials of 1 to 1,000, so you had 2 doses of racemic epi if you needed it?
Oh, racemic.
No, we're not carrying racemic epi.
No, but we have in physician control option,
I know, I wrote the protocol.
3 milligram via nebulizer.
Yeah.
So right now, we're only carrying 2.
That's a minimum number on the formulary.
Right, and that's regular epi, that's not racemic.
Okay, excuse me.
That's 1 to 1,000 also.
1 to 1,000.
Okay, so the motion was suggested 2 doses as a minimum. Is that going to work?
There's very few medications that change. So why wouldn't we not stick with the same amount and figure out the medications that have changed? We're reinventing the wheel here.
All right, so go ahead, Tom, make a suggestion. What's changed?
I have highlights show everything that's changed. So we went through, he has one in front of him where we went through and highlighted every change.
Those are the only ones that need to...
So aspirin previously said 1, or no, aspirin previously said 1. So 1 PO chewed isn't correct. So I changed it, I suggested a change of 1 bottle or 8 individual tablets. Atropine doesn't really need to change, but we just changed they had little stars next to the previous ones. And instead of stars, I put numbers. Atropine doesn't include the atropine included in the DOH field deployment stock. Dexamethasone was the new one. We had decided a total of 20 milligrams, I believe, at the last meeting.
Yeah, that was all.
Epis, any of the ones where it said IV, GTT, I think they were trying to say IV drip. So just changed it to drip. The question about the epi nebulized, how much you needed for that, 2 didn't meet the 1 to 1,000 epis nebulized didn't meet the medical control option. Haldol,
So if we have a published protocol, how difficult is it, with a few possible exceptions to be discussed, to match the protocol?
I'm gonna throw something weird out here. So it says that the minimum number of medications will be determined by regional procedure. Would it be feasible, seeing that this region has so many diverse agencies and transport considerations, to simply leave it to the REMAC to state that the agencies need to make responsible decisions to be able to carry out the protocols for their patients?
Well, I think
They
once
can
we
determine
establish-
minimum standards?
Well, minimum, I think, is where we probably should weigh in.
I think we've seen in the past where
Not a
Medication that was
maximum.
added was Decadron, and we've already established that that's gonna be 20 milligrams. So if we use the same formulary from the previous protocols, that's the minimum, and the agency has to make that decision.
Correct, and just add your Decadron
And just add the
to 2 doses.
You know, we obviously,
Okay, let's keep it simple.
so I would recommend that we just transfer the numbers from the previous protocol, except for the Decadron, which wasn't there, and just say that that's 20 milligrams.
Okay, however, in the previous protocol, it says you have 1 aspirin on board. It doesn't say 1 bottle, it says 1 aspirin. It needs to be
But that's a minimum.
just 1 aspirin for the entire ambulance?
Might as well make that 4.
So make it a 1 bottle, just put the word bottle in there, but
So
1
I can have
aspirin.
1 bottle that's full or 1 bottle with 1 aspirin.
Or 8 individual tablets, but 1 aspirin doesn't do it.
Let's say 8, let's go with 8.
Anybody
Okay.
that would put that on there can't even follow the protocol.
A minimum of 8 aspirins.
There's a motion to have a minimum of 8 baby aspirin, or 1 really large baby. All right. We gotta move on. We could spend all day doing this. What's the next item, Phil?
The next item is nasal intubation, if regionally approved list of alternative airway devices available through each regional program agency. And then we double the RSI thing, ET only if you have entitled waveform. I'm not quite sure what meant by that, but regional approval apparently is called for in these protocols for nasal intubation, and there is an approved list of alternative airway devices called for also.
And you don't have to have all the alternative airways, do you?
No,
Just a list of approved,
Okay.
what the options are.
If I can just speak to this for a second. Nasal intubation is still a paramedic level skill per New York State. Just be careful if a region decides to take away from minimum standards that are in the ed standards. Because I think you're going to put your providers in an interesting position.
Dr. Markowitz voted nasal intubation down. He said there aren't enough trained people to do it, and it's infrequent. So for the record, no. His answer on nasal intubation was no. I presume he means for anybody, but I'm open to the suggestion of what the region wants to do.
I'm sorry, guys, I didn't hear.
Nasal intubation, Dr. Markowitz says no,
Okay.
times 1. Okay, so but he's not here.
I would
So-
agree with that. I would support that, Dr. Markowitz, voting down nasal intubation.
As a skill within our region.
Yeah, I think, I've never done it. It's very rare. There's plenty of other airway alternatives now that are much more commonly used. I can't imagine someone saying, I can't get any of this other stuff that I use all the time to work. I'm going to nasally intubate this person.
What would you use differently? I've done a bunch of them, and I work in a rural environment as a provider.
I mean, you're not able to get, you've done a bunch. I mean, this sounds, I haven't seen the airway that you can't get with one of the methods that everybody's trained in and uses on a regular basis.
Like what? I get, because nasal intubation is an awake patient skill, right?
Right.
So what would you use in place of nasal intubation?
What I've been using for 15, 20 years. I mean, that I don't have a need for it. Maybe in the EMS community there's a need for it, but I don't see anyone doing it. I've never seen anyone come in 15, 20 years nasally intubated. So who's going to be doing it? Where are we going to be training these people to do it?
So every paramedic is trained to do it. At least coming out of school, every single paramedic is trained to do it.
I've been trained to do it too. I don't think I would be
Sure.
comfortable doing it.
My concern for a region like this is you don't have a lot of paramedics. You certainly don't have paramedic backup. You have long transport times, and you don't have RSI. So CPAP is probably going to help most of this, but you're crashing CHF or COPD or asthmatic, whatever, that won't have an opportunity for what you guys do in the ED for skills, resources, and backups?
There's a lot of EMS people here, you know, I mean, I'll take other opinions, but, you know, I've never seen anyone come in intubated. Does that imply that there's a strong need for it? And if there is a need for it in the one case, are they gonna really know how to do it, or are they gonna make matters worse?
I have seen one case, somebody nasally
And
intubated.
how long have you been practicing?
30 years. But I think that this may, for physicians, this may fall into the realm of cricothyrotomies, right? So we all in the emergency department get credentialed in crics, right? How many have actually done one? So it may be a rare skill, but you know, when you're up against it, do we want to say you can't? That's really the question in the protocol. And right now it is in the protocol, right?
It's a regional option.
Regional option. So,
I
It has
mean,
been in the past, however, with the new protocol, it's up to the region.
Can you make it an option paramedic level only?
yes, it is. Well, I think that we're going to go by the educational. So all those in favor of nasal tracheal intubation by paramedics only when the need arises, but not too often, and make sure you tried other things first. All those in favor? Any opposed to that? I heard the discussion. Dr. Markowitz would say no, but he's not here. So.
I did write a potential policy for the region on this that would outline the training, the didactic, the skills assessment, the documentation, QA, QI of all attempted nasal endotracheal intubations, carry a BAM. I just started with something. It can be changed.
You can share that with the education committee. Next
Happy
item.
to.
Phil.
I'm sorry, did I pass?
Yes.
Yeah, what?
Paramedic.
Paramedic.
Yeah, paramedic only.
Approved list of alternative airway devices.
Oh, approved list. So King Airway, Combi Tube, supraglottic airway, the salt airway, and the LMA. Do we want to declare one of the above, or do you want to say pick one, pick two? Do you want to approve all these? Are they all equally effective? Probably not.
And which study you read?
I don't think a region can endorse a specific product.
Yeah, that's true, Phil. I mean, Howard just. Yeah, we could
Central
have-
New York did it for, Central New York and Mid-State did it for years.
Okay, so I don't think a region should.
Right, so I'm more of
So-
I mean, if you just approve that whole list and let the agency choose which one they want, you're golden.
Or make it general and say supraglottic
Yeah.
airways.
Yep.
So a supraglottic airway device, and we should we should tell the agencies what the current options are without picking one.
Absolutely.
All right.
And then you're not endorsing one product.
Right. We don't want to have to do financial disclosures here. So Phil, did you get that one?
I got it.
So we're going to say, you know, pick a supraglottic airway to have as a backup.
Just want to go with it.
All right.
Okay. Next one is cardiac arrest, STEMI and ROSC patients to a hospital capable of primary angioplasty if feasible, with a transport time recommended by regional procedure.
Okay. So why don't we use the same one for STEMI, which is an hour? Does that make sense?
Question mark?
So Howard's mumbling to himself over here, but Howard, speak louder.
Do you want all levels of care to do that?
Well, I mean, so you come across a STEMI, the AED advises shock, and now you got a guy with a pulse, but he's comatose. You want the police department to transport him to the PCI center? I would say no.
Do you want the BLS crew to transport them to the PCI?
I would say
center?
no.
Okay.
Do you want the
you're gonna have
AEMT
stay
to do
there.
that? Do you
Yeah,
want the
the
CC
AE
to do that? I think this is a paramedic level only.
Well, our current region would include CCs, right?
CCs don't have the ability to interpret 12-lead EKGs based on the curriculum. They obtain them, but they're not taught
We don't care.
But do they need to?
We don't care. If Dr. Marquette, the onboard computer, says this is an acute MI, and you just shocked him out of defib, and now he's got a
He's
pulse.
dead and now alive.
Yeah.
Yeah.
Dr. Marquette.
But do you want them, question comes down to, do you want them to the closest for stabilization, or do you want them, I mean, trauma triage protocols say you go to the closest hospital for stabilization.
For airway, et cetera.
I think if you know STEMI and Ross, get your paramedic or CC, you should probably take them to a primary facility, because otherwise you're just wasting time.
Well, within that hour, depending on where you are in the region, it's just not feasible. It's not feasible for me to get there in an hour. I
Right.
mean,
Then you go local.
So you go PCI if within 1 hour, and level of training on board is,
CC or paramedic.
Okay,
is that all right?
gotcha.
Okay.
Advanced EMTs and tactical EMS may be trained and equipped for needle chest decompression, but the agency must be approved by the REMAC.
How many AEMTs do we have in the region?
That's
How many?
actually the largest growing number of certifications.
You're talking about AEMTs now?
Percentage-wise.
We have 9 of them in the region currently.
How many of them are assigned to tactical units?
How many are assigned to tactical units? Damn few.
How many tactical units do we have in the region?
None to
There's
my
another
knowledge.
Well, me thinking.
All right, so create a positive statement out of that. So if you're an AEMT and you're attached to is there a certification for a tactical EMS?
Yeah,
There probably is, I'm not familiar with it, frankly.
Okay, so if you're attached to a certified tactical EMS agency and you're an AEMT, the answer for needle decompression is?
No. Deb, I don't think this is in the AEMT curriculum, right?
It is.
Standard.
This was a
It
topic
is.
at
This is a-
CMAC.
So this had to have been because of the state
This was
police,
approved.
right?
Right, so this was a topic at CMAC, and.
Artie Cactus.
I guess good, right.
They had to, it requires special training because it is not in that.
Right. I would suggest no on this one.
But is it, all right, so here's another question. Does tactical EMS have a medical director?
Yes.
Can the medical director train and prove the skill
Yes.
for an
Yeah.
EMT?
And actually, there's more of those guys in the region that just aren't online in the region than you think.
Right. Right.
Like, I'm thinking Maynard Fire has 1 or 2 of them, there's one in Amsterdam. That's all your CSER guys.
No, this is all New York State Police.
It's also a basic skill for the military medics, your basic corpsmen or whatever, that are coming out, that are coming in here, back into civilian
They
practice.
still have to go through
Yeah,
this.
Oh, yeah, they still have to go through it,
If
no
they do
doubt,
it and the patient
but
doesn't need
just
it,
be aware of
they're
that.
not gonna kill the patient.
When Howard's wavering, first he said no, now he's saying you probably won't kill him.
Probably.
Probably, yeah.
It's got to be regionally approved.
At least not on the right
So the
side.
REMAC would have to approve the agency to do it. So it's got to come here first, and at that point in time, either training and ed creates a.
So it's not tied to the individual, it's tied to
Correct.
the agency, right?
Correct.
So you can turf it to the training and ed committee if that's
All
what
right,
you're
good.
thinking, Gus.
Good,
Training
nice
and ed.
suggestion, Harry. All right, Phil, next.
Okay, general, agitated patient. Ketamine and Haldol may not be available in all regions. It is available here, however.
How long?
I'm not quite sure what action had to be taken on that. We already got it.
What about ketamine?
What, does that have a page, do you have a page reference number on that?
2829.
Thank you.
It's
2829.
available for here, ketamine is. If you so choose to do the paperwork and carry it, you can have it.
So
And
it's
you're at the
already,
paramedic
Yeah.
level.
That was the
Yeah.
question that came up, was everything that was approved before carried over and still approved?
Yeah.
Right.
I mean, we have it, I don't know why that's.
so you have quite a
Well,
menu to
there are
choose
some
from
regions that
for,
don't,
Yeah.
that didn't have the Haldol previously, so.
But now they do.
So now they have the option, but they have also have the option of not.
where's that? Where's
Yeah,
that?
the regional are not approving Haldol.
Yeah. Okay,
Protocols. Excited delirium. All use of protocol may require agency MD review or regional QA, depending on regional procedure.
so the answer here is, times at least 2, Dr. Fisher can weigh in, is yes. Any utilization of excited delirium protocol should be reviewed by the medical director.
Review by medical director, okay?
So you leave it at medical director, not regional QA?
Yeah.
We don't have a regional QA, so
Good.
that's another discussion.
For another day.
Hypoglycemia. If the patient wants to sign off and you administered any medications, including oral glucose, regional procedure may require you to contact medical control. So what's your pleasure on that?
Yes, contact medical control for sign-off.
Okay. Interfacility transport. Well, there's that phrase again. The last 3 bullet points all have things that deal with each region or regional procedure. I think maybe that's already been dealt with, to be honest with you. Tony, what do you think?
It's clear as mud.
That's part of the SCT discussion, right? Sort of like,
So we gotta work on that one, it sounds like.
yeah.
RSI, the same thing, page 77, 78, regional policy and procedure determines credentialing of paramedics authorized to utilize this protocol and any additional directives pertaining to RSI. This is something we already dealt with, I think, earlier. Final one, smoke inhalation. Cyanokit may not be available in all ambulances, may not be available in all regions. It may be available for response to scenes through county fire, EMS coordinators, or is otherwise regionally established. So in other words, does the regional want to, as I read this, does the regional want to establish something about cyanokit availability? It's available here through St. Mary's Hospital, if I'm not mistaken.
Correct.
In these top 3 counties.
How are you gonna get it though to the squad?
Ground transport, I presume.
Just keep in mind that all the helicopters carry it as well.
Do they?
Oh, they have cyano kits on every single
I didn't know
helicopter.
that.
Do the counties carry it? Seago's does.
Hamilton does not, and I don't know about Fulton, but
There's certain agencies that have it, but not
They're
like the
expensive.
county.
And it expires
Mary's has it
probably.
in their
Yeah, there's 10 helicopters in New York State. Anywhere in New York State, you can get a helicopter in 20 minutes as long as they're not on the call, 40 minutes if they are.
Or it's not raining in Canada.
Or a lot in Ohio. Oh, I'm sorry.
It's also available in every emergency department.
I think so, yeah, it's part of most EMS preparedness.
St. Mary's has got it available. I don't know about Next Latour. Does Next Latour have cyanokits?
I don't know for sure.
I'm sorry.
I think we did try to have one.
Gus, that's the
Howard, how
list.
much do they cost? Dr.
Good.
Daly should borrow it.
Is there any other,
13, I think?
A lot.
any other business?
So basically, the last one, if you can get it to the scene, go ahead.
Yeah.
Okay.
So
And
it's approved for
the
use.
first one, the minimum for each medication, you're gonna put that on the agency?
We're gonna take Tom's suggestion, import what existed, except for the
No,
decadron.
in the previous one, protocols except for decadron is going to be 20. And ask for
20 milligrams? Because she has, Beth has 5 boxes.
milligrams.
So that's 2 boxes.
20 milligrams.
20 milligrams. We have the 4 milligram concentration, that's why.
So,
Okay, and then just another thing that came up quick, under the pulseless VFib VTAC protocol, it says amiodarone 300 milligrams diluted in 20 milliliters of saline. The docs want to weigh in on how we do that because we're already running a 500 bag for the patient. Are we diluting the 300 in 2 10 milliliter syringes? Are we putting in the 500 bag and waiting until the whole 500 bag runs in? You want to hang a 100 bag?
I mean, the ACLS says over 2 minutes, right?
Yes.
So that's gonna be our order. Amiodarone over 2 minutes, I believe.
Didn't we previously put it in a 100 bag and run it in a 100 bag? Yeah,
That'll give you 2 minutes. Wide open.
Yeah.
wide open 2 minutes. You can mix it in a 100 bag and get it in fairly quickly.
But that says in 20. If you're putting it in a 100 bag, that's not in 20.
Still 300 milligrams either way.
Yeah.
Just
whether
put in the
20 or
bottom,
100.
20 of the,
But does
I'm
it
just
specifically say 20?
That's why I'm asking the question. If it says specifically 20, what do you do with the other 80?
burettes. Bring back burettes.
Now, the other question comes up on that, the repeat dose is 150. Does that also have to be diluted? Because it doesn't say anything in the protocol about it.
Per ACLS, it's got to go in over 2 minutes.
Over 2 minutes also? So same thing, 150 and another
So
100
you're
bag?
not really diluting it, you're just, because it's still 150 milligrams.
And then,
I'll give these instructions to my nurses, you know, it's like 300 now. It's like, okay, they figure it out. So,
I thought the nurses told you guys what to do.
yeah, they did. It's like, would you like this? Yes, I would.
The only other item of business is from our friends at Sydney EMS, Dan Wygand over here, who has been very helpful about cyanokids, by the way. I appreciate that. Didn't know the Hills had that.
Yes.
Sydney,
I gotta rephrase that. Life Men of New York helicopters carry cyano kits. That's
Ballpark
what I'm
$1,200 before
speaking.
shipping, but you get a package 12.
Dana had
Sale.
a brief discussion we wanted to initiate about the SCT for Sydney EMS.
Yeah.
So,
Gus shut that down.
oh, okay, all right, I just wanted to bring it up.
Because we can't resolve it right now. It's
Yep.
like, it's in the education committees.
Pretty much
Yeah.
answered the question anyway, so.
So at this point, I am confused as you are, I think.
Well, at this point, my
We don't
medical
have a
director, if he
designation
approves
of-
medications with our training, then we can transport it, is what I'm getting out of it.
So you're letting them do, you've agreed to let them do these transports without presenting a program here too?
With Dr. Markowitz's blessing.
It's not Doc, it's Dr.
Manny Gazzano.
Gazan.
And Markowitz is working closely with us on
Okay.
that.
Yeah, I think we're kind of in some sort of limbo state relative to what SCT means, what the definition is, what are the requirements for it, et cetera, et cetera. It's kind of hard to drop
There is
a
no
hammer
direction.
on that.
And RSI is not gonna be possible for Sydney EMS.
Okay, well, join the
We
committee.
don't have any paramedics.
You're gonna
Just,
soon.
Gus, real quick, not to throw salt in the protocol wound, but
Truly.
one thing that we're having a little issue with is the removal of nitropaste and Lasix from the protocol with our extended transport times due to the rural nature of our EMS. Just wanted to throw it out there for some discussion to see if there's anything that we can work. I mean, I've personally received medical control orders for both medications on flash pulmonary edema patients that are hypertensive.
So it got, what other options are there?
Nitropaste is important because once we start CPAPing somebody, how do you nitro spray them?
Right in the,
Yeah, right.
the
It
tabs
burns their
are, the
nose.
tabs are even more fun.
Put it in their eyes, that'll work.
Yeah.
So Mickey, are you talking about interfacility transport?
No, I'm talking about regular EMS.
All right, but a long transport at the front end of that, and Lasix might have a chance to work, is that the basic
Absolutely.
idea?
So what
Absolutely.
they did is they stacked.
It does work.
So they just went with sublinguals, right? They're using
Correct.
the lingual
Correct.
approach.
They took the paste out and they took the Lasix out.
Is there a cap on how many doses you can give of nitro? I think it enters medical control after the third.
But the barrier to that is anybody that we have in that condition, we're CPAPing automatically.
Right.
So how do you do both?
Yeah, how
I
do
mean,
you do
can't
sublingual
keep taking the
nitro
mask
for
off
somebody
because
who's
it's
in
counterproductive to the
Yeah.
treatment you're providing.
It's lingual.
In the
It's
video,
not
that's what he
sublingual.
actually said, though.
What, take the mask off?
That's,
Yeah, but
Dr.
not-
Dilly in his video
Right.
said, take the mask off.
But not only is that labor intensive for a single provider in the back of an ambulance, CPAPing a critical patient, when NitroPaste works fine, we've been using it for years, without a problem.
Here comes your retirement. You know how WD-40 has that little red adapter to it?
There you go.
That's why I said make the CPAP mask with a little flip down thing. You just
No,
stick it
just
right
your
in.
nitro sprayer. Get one of those little WD-40 extension thing. You can stick it right in the hole of the Bouginak and get it on the
Bouginak guard, yeah, and our nitro sprays already come with that, I believe. They have a
Paste
small.
is fine.
Is that something that our REMAC can put back into our regional protocols and say, hey, it's okay for you guys to do it, or is it
It would be
nixed?
painful.
It's
It would
nixed.
be very
What
painful,
was the rationale for taking it out, just out of curiosity?
taking paste out.
Yeah.
I don't know.
The thought process, I wasn't there, but it probably was that, it takes a long time for both Lasix and nitro paste to really work. So that what the purpose of doing it is probably the thought. I guess that, you guys have longer transport times, it might make more sense for people who have longer transport times to use those two medics, but.
It'd be very
It'd be
painful to
15 minutes.
change the protocol.
Well, instead of changing the protocol, what if the agency, we approve it, that the agencies could carry it and then leave it completely as a physician option? Because like what he's saying, he got orders for
It's
it.
still changing the protocol because you have physician options in the protocol, which would require CMAC approval.
And it's also been removed from the formulary.
Mhm.
So both
Well, we could do, you could go
options-
back to REMO or the collaborative protocol and say, may have been an oversight, what do you think about putting this back in? I don't think it would take too long, I mean, it may not be that painful, but
It would still have to
it
go
has a process, so
CMAC
we
consent bill.
can't do that.
But you'd have to start the process now to have it go be presented in the fall.
Right. So if there's any similar, sort of micro adjustments to the protocols, we would put them all together and suggest it back to the collaborative protocol. We'll go back through the CMAC They might adopt it. I mean, maybe the collaborative protocol itself, Remo and Mountain Lakes would all adopt it. Right? But it's, this is sort of the flip side of doing a collaborative protocol. If you want to change it, you have to go back to the Vatican.
And genuflect.
Probably be easier to go to the Vatican.
Probably the Trump have to, hey, you know, see the Pope. I mean, how hard could it be? Like,
I'm just picturing Mike Daly in a hat.
but I think, you know, I think Lasix, the removal of Lasix, I think makes sense because of the untoward effects and death associated with Lasix, not just pre-hospital, but Lasix has definitely been seconded by nitroglycerin as first-line therapy for congestive heart failure. So if their pressure is decent, it's nitro, 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 nitro. And unless they're volume over, you know, if they're volume overloaded, then Lasix makes sense. But some of these people get into heart failure. You look at their ankles; they're not volume overloaded.
Why don't we just bring back the nifedipine capsules that you had to pull?
People died from nifedipine. So that's probably the rationale. Probably why Lasix went out, because it's kind of out of ED practice, except for cardiologists still ask for Lasix. It's kind of interesting. But it's evolved towards really pushing nitro as long as their pressure can tolerate it. Just reduce preload, keep going. And CPAP, obviously, you know, positive pressure. All right, so we got through the list.
That's it.
Tony, are you done? You're not going to come up with another list, are you?
Go ahead.
Get the summer off.
Tony, thank you. That was very nicely done. Appreciate it.
All right, any other business for REMAC?
If I may, we just wanted to bring something up. Until recently, we were unaware that it was needed to come to the REMAC. I've been talking with Amy Johnson. We were looking to try to, if anyone's familiar with pre-hospital point-of-care ultrasounds, it had been debated many years on whether it's effective or not. There's a lot of evidence out there, a lot of studies out there, but to date there's nothing really been done here, at least in New York State, to prove whether or not it can be done with any degree of accuracy. It's surmised, you know, on both ends. Some say, no, it can't be done, and others swear up and down that within 6 hours they can teach a potato to do fast exams.
I've never seen a teachable potato, but
Eject enough epinephrine and norabine and teach a potato to do anything. So without any sort of evidence on basis of whether or not it can be done in the field with any high degree of accuracy, we had wanted to approach CMAC with a purely educational study, not directing any sort of change of protocols, patient care, or treatment options or hospital destinations, but strictly asking the question of whether or not, under the medical direction, with proper training to ACEP standards, whether or not paramedics can accurately do this in the field. And then, based on that information, whether or not, you know, then you can talk later on down the line of whether or not ultrasounds are a viable option, much like the pre-hospital 12 leads. You know, when we had the 12 leads come out in the field, a lot of people were skeptical whether or not it can be applied out in the field on the pre-hospital.
I think ultrasound is very different from EKGs, which have been around since 1968. Ultrasound, you know, the pre-hospital care is often an extension of the emergency department. Mm-hmm. There are many ED providers who are not credentialed in ultrasound.
Correct.
And so, you know, when you say ultrasound, there's like at least, you know,
correct.
12 modalities.
We're talking about point-of-care ultrasound, answering a yes or no question. Not
no, there's at least 8 of those,
mm-hmm.
right? So there's ultrasound for vascular access, which I think would be the best bet,
mm-hmm.
right? You want to do a line, and this guy weighs, you know, 500 pounds, and you can't see anything. That would be an interesting study.
Our aspect, we're looking at vascular access as well as doing fast exams.
Fast exams are going to not advance the cause, because when they hit the ED, no surgeon's going to buy that evidence. ED physician, if he's not credentialed,